Bonjour, je suis Jonathan Bramson, le président du conseil d'administration pour le Centre d'excellence sur la douleur chronique pour les vétérans canadiens. Good afternoon, my name is Jonathan Bramson, board chair for the Chronic Pain Center of Excellence for Canadian Veterans. Avant de commencer notre forum, j'aimerais reconnaître les peuples autochtones
I would like to acknowledge the indigenous peoples of all the lands that we are on today. While we meet today on a virtual platform, I would like to take a moment to acknowledge the importance of the lands which we call home.
Before we begin our annual forum, I would like to acknowledge the indigenous peoples of all the lands that we are on today. While we meet today on a virtual platform, we must take a moment to appreciate the importance of the lands which we call home. With regards to the Center of Excellence, it is important to recognize that we are located on the traditional territories of the Mississauga and Haudenosaunee nations, and within the lands protected by the Dish with One Spoon Wampum Agreement. We make this acknowledgement to affirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. Indeed, the recent announcement of the discovery of children's bodies who attended residential schools is an important reminder of why we need to continue this work to educate ourselves and actively participate in reconciliation-focused activities. L'été 2019, le ministre des Anciens combattants Canada a annoncé que
the Minister of Veterans Affairs Canada announced that Hamilton, Ontario would be home to the Chronic Pain Center of Excellence for Canadian Veterans. To support the growth of the Center of Excellence, we used the existing resources of the Chronic Pain Network, McMaster University, and Hamilton Health Sciences Corporation. Together, they have enabled the Center of Excellence to engage immediately with veterans.
Within the first year, the CPCOE has been able to structure a research center that has identified and provided supportive research to those experiencing chronic pain. The Center of Excellence is using patient-oriented research with veterans selecting and shaping the research projects that receive funding. The next critical step will be for the center to mobilize the research outcomes in a manner that puts these results into practice. I am proud of the work that has been accomplished to date and remain cognizant that the success of the Center of Excellence can only be measured once research outcomes have begun to demonstrate a positive impact on the well-being of veterans suffering from chronic pain and their families. Merci de nous joindre pour célébrer la
Thank you
première
for
année
tuning
du
in to
Centre
celebrate our
d'Excellence
first
sur la
year as an
douleur chronique.
organization.
Et j'espère que vous
I
aimerez
hope
le
you
forum.
enjoy the open forum.
Thank you for tuning in to celebrate our first year as an organization, and I hope you enjoyed the annual open forum. And now I'd like to invite the Honorable Lawrence Macaulay, Minister of Veteran Affairs, Canada, to say a few words.
I want to say hello to everyone taking part in this year's AGM and to let you know just how much we appreciate the work you're doing. Too many of our veterans deal with chronic pain, and it's usually invisible, misunderstood, and hard to diagnose. But you're changing that. The research you're doing at the COE is helping find better ways to treat chronic pain, and because of that, you're helping veterans lead better lives. I'm very proud of our partnership with the Center and to be able to support the great work you do every day. Thanks again, stay safe, and take care.
It is now my pleasure to introduce to you Dr. Ramesh Zacharias, who is the CEO of the Center of Excellence, to present the annual report.
Thank you, Dr. Bramson. Bonjour tout le monde.
Hello,
Et bienvenue
and welcome
à notre
to our first
premier
annual
forum
open
ouvert
forum
pour le Centre
of the
d'Excellence
Chronic
sur la
Pain
douleur
Center of
chronique
Excellence
pour les
for
vétérans
Canadian
canadiens.
Veterans.
Je suis le
I
Dr.
am
Ramesh
Dr.
Zacharias,
Ramesh Zacharias,
chef de la direction
CEO
et
and
directeur
Medical
médical.
Director.
Au Centre
At the
d'Excellence,
Center of
notre
Excellence,
mission
our
est
mission
d'améliorer
is to
le
improve
bien-être
the
des vétérans
well-being
de
of
nos
veterans
forces
of
armées
our Canadian
canadiennes
forces who
souffrant
suffer
de
from
douleurs
chronic
chroniques
pain,
et de leurs
as well
familles.
as their families.
J'aimerais commencer
I would
par
like to
remercier
start
les
by
vétérans
thanking the
qui se
veterans who are
sont
with us
joints
today
à nous aujourd'hui
for
pour
their
leur
service.
service. To the veterans who have joined us today, thank you for your service. Canadians owe all of you a debt of gratitude for the peace and safety we enjoy in this country. I want to thank Minister Macaulay and the team at Veterans Affairs Canada for their trust and confidence in supporting the Center of Excellence for Chronic Pain for Canadian veterans. I also want to thank the leadership team at the CPCOE for their tireless efforts in ensuring we made veteran well-being at the heart of all we do. Later today, you will hear from Dr. Norm Buckley, our Chief Scientific Officer, and Dr. Jason Bussa, our Scientific Director. The two of them ensure that with veteran input combined with researchers from across Canada, there's a renewed focus and dedication to meeting our mandate. A major reason we were able to launch 7 months after the announcement of the awarded Center of Excellence was the great work that Dr. Buckley and his team accomplished in the previous 4 years of the CIHR SPOR grant in establishing a national chronic pain and research network. We were able to leverage their experience to launch the CPCOE network. When we were awarded the Center of Excellence, we made a commitment to ensure veterans played a significant role in both oversight and providing guidance within the management team. I am pleased to report to you that we have been true to that commitment. Firstly, when developing our 9-member board of directors, we recruited 4 veterans with over 150 years of service in the Canadian military. Secondly, in September 2020, we convened our first in-person 10-member advisory council of veterans who have and will continue to determine the research priorities, ensuring we maintain our focus on veterans and family well-being. The advisory council is chaired by Tom Hoppy, who is also a veteran. In addition, 2 of the members of our scientific advisory board are also veterans. Thirdly, our director of operations, Paul Roos, is a 9-year Afghan veteran. These foundational principles have played a key role in ensuring the CPCOE maintains its focus on meeting our goal to keep hope alive for veterans suffering from debilitating chronic pain. This past year, we initiated 3 sentinel research projects. Dr. Melanie Knoll of the University of Calgary is studying the impact of chronic pain on the family of veterans. Dr. Joy McDermott of Western University is studying the impact of sex and gender on chronic pain in female veterans. And the 3rd research project is being led by Dr. Vikas Parihar and Dr. Greg Tippin from McMaster University in collaboration with Dr. Don Richardson of the Operational Stress Injuries Clinic. This research will study the impact of cannabis on veterans, focusing on pain, mood, and sleep patterns. Prior to the commencement of the CPCOE, we traveled across Canada to meet with veterans and their spouses. We wanted their feedback on what issues we should address. In the fall of 2019, I met Rob and Christine in Edmonton. I spoke with them last month, and I'm thrilled to report that Dr. Melanie Knoll has included Rob and Christine as co-investigators in her project, a real-life example of patient partners in research. I've always maintained that for the CPCOE to succeed, we need engagement with veterans and their families. We plan to focus on delivery of that aspiration in our 2nd year of operation. Our message to them is captured by Desmond Tutu, who said, "Hope is being able to see that there is a light despite all the darkness." As mentioned earlier, in the fall of 2020, we held our first advisory council of veterans in Hamilton. We are very fortunate that the 10-member advisory council combined have over 200 years of service in the Canadian Armed Forces. One of the members was Francois Duperry. Frank had a smile that would truly light up a room. His positive attitude was and will always be an example of true resilience. In April 2011, the course of his life was changed. The soldier born in Sept-Îles was the victim of an attack by a suicide bomber loaded with 150 pounds of explosives, which detonated 2 meters from him. Frank miraculously survived, but the list of his injuries was long. A punctured eye, fractured jaw in 12 places, a shattered eardrum, loss of a lung, as well as use of a hand, and over 200 scars all over his body. In the documentary March to the Top, Francois Duperry said when he arrived at Mount Everest base camp during the expedition, there are two ways of seeing ce qui m'est arrivé. I still have an arm to hug my children. I still have an eye to watch them grow. With one eye, I can see it all around me, he said, looking at the grandiose landscape. That's enough. I don't need to. Sadly, Francois passed away this year due to an unexpected accident. In the end of July, the CPCOE will honor Francois' memory by supporting a Francophone researcher in their quest for further education and understanding of chronic pain in veterans. We are committed to ensuring Francois Duperry's legacy lives on. To his parents, we want to thank you for sharing Frank with the world. And now I would return this to our chairman, Dr. Jonathan Bramson.
Thank you, Dr. Zacharias. I would now like to introduce to you Dr. Jason Bussa, the Director of Research, who will provide an overview of the research accomplishments in the past year. Jason?
Thank you, Dr. Bramson, which I'm happy to do. So to begin, we are quite interested in the optimal treatment of veterans due to acute pain. All chronic pain begins as acute and if properly managed may not transition to chronic. We undertook a large review looking at all available therapies available for treating acute musculoskeletal pain. And we found compelling evidence that topical non-steroidal anti-inflammatory agents followed by oral NSAIDs, acetaminophen, and acetaminophen plus diclofenac showed the most attractive benefit to harm ratio. And importantly, we found that opioids did not achieve greater benefits than these alternatives, but they were associated with the greatest risk of harms. So taken together, this evidence provided compelling reasons to avoid the prescribing of opioids for acute musculoskeletal pain. We found a number of non-pharmacologic therapies, for example, transcutaneous electrical stimulation, that showed the potential for important benefit without risk of harms. But currently, these non-pharmacologic interventions are supported by low certainty evidence only, suggesting that these are important areas for further work. We also explored risks for prolonged opioid use. We know that a number of veterans who suffer from an acute injury are started on opioids, and there are a certain proportion that go on to experience prolonged use. We were curious about how common this was taking place and what factors were associated with that. And what you can see here is we've broken down the risk of developing long-term opioid use in the general population is about 6% of all those who begin a prescription. But in the high-risk group, which includes veterans, that number is closer to around 26%, 27%. Interestingly enough, there are two studies here of the same group of veterans, and before they began a number of strategies to provide options for alternatives to opioid prescribing, there were about 29% of veterans that were going on to prolonged use. And after they introduced a new program to try to reduce the use of opioids and provide alternatives, that percentage went down to 17%. So it does appear as if things can be done. In cases where opioids are used for acute pain, we did find certain factors that are important to keep in mind to avoid high-risk long-term use. And that's avoiding prescribing to individuals with these acute pain complaints that also come in with a past or current substance use disorder, keeping prescriptions to 7 days or less at one time, and using lower dose formulations for that prescribing. So this information has been put together in a recent clinical practice guideline by the American College of Physicians, and we're hoping that it will help optimize use of opioids and optimize treatment of acute pain in general. When we look at opioids for chronic pain, we understand some of the risks. Addiction, overdose, sometimes can be fatal, but there are some risks that we don't understand that well. One is something called opioid-induced hyperalgesia, and this appears to be a situation in which in some patients, the use of opioids over a long term can paradoxically increase their pain instead of decrease. It's a very poorly understood phenomenon, and so we set out to survey about 850 clinicians that deal with chronic pain patients to ask them about their experiences in practice with this poorly understood adverse event. And what we found was that 3/4 of them reported that they had believed they had seen opioid-induced hyperalgesia in at least some of their chronic pain patients. And over a third felt that it affected more than 5% of their chronic pain patients prescribed opioids. So most agreed this was a complication, but there was a lot of disagreement and uncertainty about how common this event was or how it should be optimally managed. So we're interested in continuing to explore this phenomenon so that veterans living with chronic pain and their healthcare providers can include this information in their decision-making around use and continued use of opioids. In 2017, our group put out an evidence-based clinical practice guideline to attempt to optimize the use of opioids for chronic non-cancer pain. But it's important to understand the factors that are associated with uptake of this kind of information and what we can do to try to optimize that. In particular, is we have to update this guidance document in the next year and a half. So we undertook some evidence syntheses to learn about this. The first one was looking at factors that were associated with better adherence to guideline recommendations. And what we found is that, unfortunately, historically, adherence to guideline recommendations has not been very good. And we found that lack of familiarity with guidelines was a major reason why. Providing very complex recommendations was another barrier towards adherence. And finally, making recommendations for which the resources were inadequate made it very difficult to follow through. When we looked at factors that are associated with improving adherence to guidelines for opioids and chronic pain, we found a couple of things here. In particular, we found low certainty evidence that things such as education, audit and feedback, interprofessional support, and providing resources to engage in shared decision-making with patients all appeared to be associated with some improved aspects of guideline adherence around risk mitigation strategies. So making treatment agreements, urine drug screening, for example, looking at databases to see if there's other medications prescribed that might interact with opioids. Unfortunately, studies to date have not shown whether this improved adherence to recommendations actually leads to improvement in direct patient-important outcomes. So we have some preliminary signals, but more work to do. Finally, we were curious about the perceptions about the guideline we put out. So we teamed up with the Canadian Medical Association last year to launch a survey to about over 35,000 physicians across Canada to understand their perceptions about the guidance that we had put out. The good news was we found 94% had read the guideline and just shy of 90% endorsed the clarity of the document as either good or excellent. We did find the majority, 86%, endorsed that the guideline was feasible to implement, but 2/3 did highlight potential resistance from patients and the lack of access to effective non-opioid treatment as barriers. So again, we can recommend pursuing options other than opioids first, but they have to be available for clinicians to follow through on that. And we found that 70% of respondents had changed practices to align with guideline recommendations. About half had engaged at least some of their high-dose patients in voluntary tapering, and about 43% had reduced the number of new starts. So we have a preliminary signal that we might have impacted practice, but we're going to have to continue work to see what the impact on patients has been and find ways to further optimize our efforts for the next update of the guideline, which will happen in the next year and a half. We're also very curious about looking at patterns of opioids for chronic pain amongst veterans. And we teamed up with the Institute for Clinical and Evaluative Sciences to track patterns in the province of Ontario, where we're able to identify which individuals are veterans and which are not. And what we found is the percentage of veterans who received an opioid prescription for chronic pain decreased by about 22% from fiscal year 2010 to fiscal year 2019. So from 17% of veterans with chronic pain down to 12%. So this includes the time period in which our guideline was released. Other factors certainly may have been at play, but we do seem to see less reliance on opioids for chronic pain in Ontario amongst veterans and non-veterans. This was also reflected in a reduction in the total volume of opioids dispensed. So again, even if there are prescriptions, are they very high dose prescriptions, which we know are associated with a potential greater risk of harm, or are those doses staying lower? And it appears as if the doses are going down as well. There was an average reduction of dose by close to 40% amongst veterans, 35% in non-veterans from fiscal year 2013 to 2019. And we're also seeing, as you might expect, the percentage of opioid recipients who are prescribed what we call high-dose opioid therapy, greater than 90 milligrams morphine equivalent, also decreased during this time period by close to 30% amongst veterans. And finally, when we looked at co-prescribing of drugs that we know can interact with opioids to increase the risk of non-fatal and fatal overdoses, such as benzodiazepines, we also saw a reduction in this potentially problematic co-prescribing, a decrease of 7.5% amongst veterans. So again, we are seeing some trends that practices are changing. It appears as if this might be coming more into alignment with current evidence, current guidelines. We have to continue to explore that these reductions in use are not seeing any consequences in terms of optimizing the care of veterans who live with chronic pain. Another agent that's becoming of great interest to veterans is cannabis. As we understand more about the limitations of opioids, cannabis is being increasingly sought as a replacement agent. It's been available in Canada for select medical purposes since 2001, but we've seen large spikes in increased use. In June of 2015, there were about 24,000 Canadians that were authorized to use medicinal cannabis. But by September 2020, this number had gone up to just shy of 400,000, and it shows no sign of slowing. We see similar increases in use amongst Canadian veterans, particularly for chronic pain, where the expenditure right now is in excess of $100 million for reimbursement of medicinal cannabis. So it's important to understand what we know about this product and if this is likely to be an appropriate substitution for opioids. So we began by looking at attitudes and beliefs of individuals that are using cannabis. And we looked before recreational legalization came into an effect. But we surveyed close to 1,500 community adults that were endorsed use of cannabis. And what we found is that 2/3 did endorse that some memory impairment was something that they had experienced. And about half were concerned about the risk of addiction, but 25% endorsed that cannabis was not addictive. So we have a lot of variability in beliefs out there that we need to do some education to better align it with the evidence. And we also learned that about 94% identified use of cannabis as beneficial for pain relief and about 80% for management of stress, anxiety, or depression. So a lot of enthusiasm out there for therapeutic applications. a disconnect about the sort of risks of harms in terms of what the evidence can tell us. We then wanted to know about patterns of usage of cannabis. So again, we went back to this 709 cannabis users this time. And what we found was 61% endorsed exclusively recreational use, but about 40% induced at least some therapeutic use as well. So it's a diverse and complex population. But of all the medical users, only 23% reported authorization from a health professional. So what we understand from this is a lot of individuals, a lot of Canadians are using cannabis for therapeutic purposes, but without guidance from a healthcare professional. So they're making these decisions on their own and without monitoring for other medications they're taking that may or may not have interactions. And we also learned that although people were using therapeutically, even amongst those that were, there was often dual use. There would be therapeutic use, but also some recreational, and exclusive medical use was only in about 20% of those that endorsed using for some therapeutic benefit. So again, it's a complex population, variety of things going on, a lot of use happening outside of healthcare guidance. So we need to sort of slowly work on this so we can make sure that use is being optimized and is concordant with what we best understand from the evidence. We also conducted research with family physicians to understand what they think about medicinal cannabis. And what we found is that they were reluctant to authorize, and this may explain why so many patients using therapeutic cannabis did not have authorization from a physician. But their reluctance was because of uncertainty around the evidence, uncertainty around the benefits, uncertainty around the harms. So we need to provide more information to help in this area. Those interested in considering use of cannabis then typically delegated use and authorization and dispensing of the product to cannabis clinics that had focused on this issue, but there was some concern that cannabis clinics may not be providing full information to patients. And finally, what we learned was that physicians were quite supportive of both research and continuing education. They were interested in continuing therapeutic cannabis, but they simply said, we need better evidence and more guidance to go on so we can provide best information for our patients. We have moved in this direction. We've put a lot of effort in the last year into developing clinical practice guidance for use of therapeutic cannabis in chronic pain. We have now developed a focused clinical practice guidance and a number of supporting evidence syntheses that have been accepted for publication. They will come out later this year, and we hope will address some of those gaps that both patients and clinicians have indicated they have around the possible role of cannabis for management of chronic pain. We've also been invited to guest author, along with Jim Thompson, a special edition of the Journal of Military, Veteran, and Family Health that will be entirely focused on veterans and chronic pain. The articles for that series have been accepted. We expect the whole issue will come out in early fall of this year and will identify a number of issues, including some recent learnings that will be entirely directed and relevant to the issue of veterans and chronic pain. And we've also been trying to learn from available data that currently exists. We've recently synthesized evidence from the Life After Service study to better understand the variability in the experience of chronic pain amongst Canadian veterans. And what we found is that although close to 40% of veterans will endorse living with chronic pain, their experiences are quite different. In the first cluster, we have about 47% of those with chronic pain that did not endorse severe pain or dramatic limitations. So they were doing fairly well, although they did endorse living with chronic pain. In that second cluster, we had individuals that endorsed a lot of severe pain and a lot of physical limitations, but not much in the way of psychological impact or comorbid mental illness. And in that third cluster, we found veterans living with chronic pain, often severe, endorsing physical limitations, and also a high level of endorsement of comorbid psychopathology, post-traumatic stress disorder, depression, anxiety. And what this tells us is that veterans living with chronic pain are a diverse group. They do not require all the same types of therapies. They're not going to be interested in the same kind of therapies. And we have to make sure that the resources that we offer are fit for purpose, that they consider not just the fact that someone lives with chronic pain, but the specific impact that chronic pain is having on them. And at this point, I'm going to pass the presentation back to Dr. Bramson to continue.
Thanks, Dr. Bussa. Quite a remarkable collection of accomplishments in the first year of this enterprise. I would now like to introduce to you Dr. Norman Buckley, the Chief Scientific Officer, who will present our research plans for the upcoming year. Norman?
Thanks very much, Jonathan. And you've heard quite clearly from Dr. Bussa the remarkable amount of work that's already gone on. Next slide, please. What I'd like to do is just present a little bit of our approach to how we structured research. You heard from Dr. Zacharias and from Dr. Bramson that we had a couple of overarching concepts here, and also we were able to bring things to fruition fairly quickly. Some of that was just good luck. Some of that was actually a result of planning. One of the things that you will have noticed from a lot of Dr. Bussa's work is that there's quite a focus on knowledge synthesis and reviewing administrative health data and guideline projects, which really are another form of knowledge synthesis, bringing them into a format that can help to inform clinical care. There's an advantage to that. I mean, the disadvantage is that it doesn't actually create new knowledge, but the advantage is that it is pretty schedulable. You have a pretty good idea of how long it's going to take. And we're very fortunate at McMaster and elsewhere in Canada to have teams who are quite skilled at this work. And you saw the ICES data, Institute for Clinical and Evaluative Studies in Ontario, which makes available health data in an analyzable format. And so that kind of work can be brought online. Turns out, even if we had planned for the COVID epidemic, we couldn't have done it any better, I don't think. Trying to do clinical trials research, for example, is very challenging, and much of that work came to a halt during the COVID crisis. So we were fortunate to have focused our efforts on the field of knowledge synthesis. So that was the initial work. We're currently focusing on trying to identify knowledge about clinical care that's specific to the care of veterans and drive that out to the network of clinics that we're collaborating with across the country and incorporate outcomes measures to assess the effectiveness of our care for veterans. And then in the long term, we do hope to engage in clinical trials that will directly address optimal approaches for treating veterans with chronic pain. Both Dr. Zacharias and Dr. Bramson mentioned the concept of patient-oriented research. So at the Canadian Institutes of Health Research, the CIHR is now into its third 5-year sequence of what they call their strategy for patient-oriented research. And this engages patients and their families and caregivers at all levels of healthcare research. We've translated that approach directly into our engagement with veterans. So as you heard, we have veterans engaged throughout the process of research. Next slide, please. For example, one of the things that Dr. Bussa didn't really spend a lot of time talking about was the fact that his team reviewed some existing priorities for research in Canada that had been developed in the early days of the Chronic Pain Network, and then worked further to bring a veteran perspective on those research priorities. What we would like to be able to do in the future is focus on new treatments, also treatments with specific value to veterans, either for veteran-specific conditions or treatment modalities to which veterans respond particularly well. And also, we would like to be collating our knowledge, the existing knowledge about optimal treatment in order to inform policy initiatives, whether they're at veterans care in the Canadian Armed Forces or elsewhere in the healthcare systems, to ensure that the resources which go into supporting treatment are actually supporting the most beneficial forms of care. We've also started to build long-term relationships and develop ideas for long-term studies with our collaborators. And to that end, we've met with representatives of the Canadian Armed Forces, the medical teams, as well as research teams, the two other Veterans Affairs Canada funded research center, the Center for the Canadian Institute for Military and Veterans Health Research, as well as the Center of Excellence for Post-Traumatic Stress Disorder and related mental health conditions. We've met with several groups of NATO partners, including our partners with the French NATO team. That was the occasion of one of my more stellar failures at communicating in French. And you'll notice today that I've been particularly forsworn from trying to communicate in French. My two daughters, who are fluently bilingual, very much support any restrictions on my trying to speak French. And so I think you have a proper translator. We've also met with the U.S. Veterans Affairs, who have instituted a number of chronic pain initiatives, and the U.S. Department of National Defense, all of whom are engaged in trials of various sorts of treatment, both for acute medical conditions and injuries and trauma, as well as long-term situations such as chronic pain. Next slide, please. Our process, as you heard, includes review at the Advisory Council of Veterans, and that's the group that really decides whether they think something that we want to pursue is relevant. As always, research dollars are limited, and so you want to be sure you're choosing projects with the greatest relevance. And we have a scientific advisory board which is able to critique submissions for their scientific merit. Our initial strategy was to direct a fair bit of activity in the first year to research teams at McMaster. And as I say, that was deliberate. We knew who they were, we knew what their successes were, and we wanted things that would take off and operate quickly. We then reached out across Canada with what we've referred to as directed calls, working with researchers with whom we were familiar. And we've now just completed, and we are in the process of adjudicating an open competition on several topic areas that had been identified through the priority setting exercise and considered important by our advisory council. Next slide, please. One of the areas that's been identified is the process, or the transition process, from active service into veteran status. And to that end, we have been reaching out, speaking with Canadian Armed Forces medical teams and research entities. And many of the issues to do with transition seem to have a compelling administrative process. And so we're working with Veterans Affairs Canada and other groups to identify the appropriate administrative strategies. Next slide, please. We have this DREAM project, a longitudinal study of veteran health, which it is a dream. It may need to be reined in a little bit, but we have begun discussions with the Canadian Armed Forces medical people, as well as the Canadian Longitudinal Study of Aging, who've set up quite a brilliant process for tracking a large cohort of Canadians. And we're looking to whether we can do something along the lines of the Framingham study, which is the famous cardiovascular risk study conducted from Harvard Medical School in the Boston area over, I think it may be still running after 50 years, but we are considering trying to replicate that idea, but looking at chronic pain. Next slide, please. You heard about much of the research to date. There are a number of things underway that Dr. Bussa didn't necessarily refer to. We have rapid recommendations, one of which we hope will see publication very soon on optimal use of cannabis for medical reasons. There's another one in progress looking at care of jaw pain. Which turns out to be a surprisingly challenging problem for the Veterans Affairs medical people. You heard about the analysis of the ICES data. One of the concepts that came from SIMVR is the idea that veterans' well-being can be assessed by looking at 7 domains of well-being. And so one of the things we're doing is identifying with the SIMVR team and the PTSD Center of Excellence the optimal ways of measuring well-being in veterans. We're developing an education platform, both for formal sessions as well as online activity that can be made accessible to veterans. We're currently, the COVID crisis created some interesting situations, and one of which was the rapid switch from in-person to online delivery of healthcare. And so we have the opportunity to look at that at I think 10 or 12 clinics across the country to see how they individually instituted online services and compare them to their previous and now resumed in-person services. And that paper should be prepared for submission in the near future. Having a network of clinics across the country, one of the things that we want to be able to see is, are there differences in infrastructure and are there differences in outcomes associated with different clinic processes? You heard, I believe, from Dr. Zacharias about Dr. Melanie Noel's work on the intergenerational impact of chronic pain. She's applying her work, which has looked at children's pain and the pain of their parents or the social settings in which they live. And she's now applying that same methodology to the children of veterans with chronic pain. This is unique work. And interestingly enough, I heard this morning that Dr. Noel has just received the inaugural Killam Emerging Research Leader Award at the University of Calgary for her work in children's pain. You heard about the sex and gender influence work. Joy McDermott holds a CIHR chair in sex and gender research. She worked both at McMaster and at Western University in London, Ontario. And the Canadian military has a long history now of having women in active combat roles. And so there are great opportunities to try to identify what are the differences in impact upon women as compared to men with respect to chronic pain and how it develops in the course of their service. We're looking at veterans' cannabis use, as you saw, and also one of our goals is to create a legacy of enhanced knowledge about research in veterans' chronic pain, and to that end, we will be supporting graduate researchers. Next slide, please. And I think with that, we will be passing it back to Dr. Bramson for the next stage. Thanks very much for your attention.
Thanks, Norm. Exciting times ahead and important work to be done. I will now call on retired Lieutenant General Michel Maisonneuve to introduce the former Deputy Minister of Veteran Affairs Canada, Walter Natinchik, who will provide the keynote address. Michel?
Merci beaucoup, Monsieur le Président. Il me fait plaisir de vous
Thank you
présenter
beaucoup,
l'ancien
Chairman.
sous-ministre
I'm pleased
du
to
ministère des
introduce
Anciens
the
Combattants.
former Deputy Minister of Veterans
General
Affairs Canada.
retired Walter Natinchuk is a perfect example of ethical and exemplary service to our country. His bearing and conduct harken back to the days when officers were indeed gentlemen. Born in Winnipeg from the union of a Polish World War II veteran and a German mother, Walter considered military service early in life. He was an air cadet for 5 years as a teenager, then attended Royal Roads Military College in Victoria. Il est ensuite gradué du Collège militaire royal de
Then he
Saint-Jean
graduated
en
from the
1979
Collège Militaire Royal de
comme
Saint-Jean
officier
in
de l'arme blindée.
1979 as
C'est alors que je
an
l'ai
armored
connu.
corps officer. That's where I
Walter a
knew him.
servi en Allemagne,
Walter
à
served
Chypre
in
avec les
Germany,
Nations
in
Unies,
Cyprus with
aux
the United
États-Unis,
Nations,
en
in the United
Bosnie,
States,
en
in
Irak,
Bosnia,
et
in Iraq,
naturellement à travers
and
le Canada.
naturally across Canada.
His 37 years of uniformed service culminated in the appointment of Chief of the Defense Staff for 4 years, the highest rank possible in the Canadian Forces. He then continued his service to our country as President of the Canadian Space Agency, and for the last 7 years as Deputy Minister of Veterans Affairs, where he brought transformational leadership to the staff and compassion for our veterans. He retired from this position in May after a total of 46 years of service to Canada. J'ai eu l'honneur de servir aux côtés de Walter
I had the
durant ma
honor of
propre carrière
serving
militaire
with Walter
et
during
plus
my
tard
own
dans la
military
fonction
career
publique.
and later in the public service.
Officier de la plus grande efficacité
A
et
highly
respect de ses
effective
collègues,
officer,
le général
highly
Natinchuk est un
respectful of his
motivateur
colleagues.
exceptionnel
General
qui
Natinchuk is
inspire
an
la
exceptional
loyauté
motivator who
de ses
inspires
subordonnés.
loyalty among subordinates.
General Natinchuk is a very fit individual and also possessed of an excellent sense of humor. My wife, Barbara, a veteran of 21 years of service in the Royal Canadian Air Force, was one of Walter's subordinates on the Joint Staff at one time in Ottawa and saw him perform many feats of strength. That is why, to this day, she refers to him as the biceps of Bytown. However, we're both happy to also call him our friend. That is why, to this day, ladies and gentlemen, General Retired Walter Natinchuk. Walter?
Et merci à vous, Michel, et vos commentaires sont vraiment généreux.
For your very generous
surtout
comment,
de vous.
especially coming from you.
Let me take this opportunity here, since I have the mic finally, to say, Michel, congratulations on the VIMY Award that you'll be receiving later this year. And for folks' information, the VIMY Award is handed out annually by the Conference of Defense Associates to those individuals who have made an extraordinary and exceptional contribution to Canada, to our security, to our peace and safety. And I could not think of a better candidate to receive that than Lieutenant General Michel Maisonneuve. Merci à vous, Michel, pour votre leadership endurant, votre contribution avec cette centre d'excellence.
To this Center of Excellence.
I would like to thank the President, Dr. Ramesh Zacharias. Thank you so much for having me on this event here today. The Chair of the Board of Directors, Dr. Jonathan Bramson, again, thank you so much for this opportunity. I want to give a shout out to the Advisory Council of Veterans. Thank you for making this contribution, your insights, your experience, in terms of what we have learned and where we need to go. It's very much appreciated. I do appreciate the briefs that have been made here today. Dr. Booth and Dr. Buckley, thank you so much. Thrilled by what I'm hearing. I am absolutely thrilled by what I'm hearing. Again, the nature of our service being so unique, there needs to be unique solutions for every one of our men and women. Encore, nous sommes vraiment les bénévoles dans la force canadienne, mais notre service
in the Canadian Forces is a form of volunteering, and our service is unique, and therefore the care and the solutions must also be unique for each member, each veteran.
And I also appreciate the brief by Dr. Buckley about where we're going into the future, and the sense that time's a wasted. We have to move out and we need results soon because people are hurting and they do want to have solutions moving forward. Listen, it's a real honor to be with you today and to recognize that the Center of Excellence has already passed its first year. I do recall when I was asked to give this brief, the great work by Dr. Sid Korshen, she is the Director General for Health Professionals and Veterans Affairs, working with the head of our research and Veterans Affairs, Dr. David Pedler, who now runs the Canadian Institute of Military and Veteran Health Research, mais même la contribution vraiment le leadership
and the contribution and leadership of Dr. Korshen and Dr. Pedler
cette innovation,
towards the creation of this innovative Center of Excellence. It is thanks to their professionalism and their leadership and their dedication
leader exceptionnel. So thanks so much, Dr. Korshen and Dr. Pedler. I also want to highlight the importance of partnerships before I kick off here. And to hear again, Dr. Buckley talk about the partnership with CIHR, the Canadian Institute of Health Research, again, CIMVAR, with our allies south of the border, with our NATO partners and those other countries that we share so much with, especially in the Five Eyes community. The reality is there are great ideas out there. There's a lot of experience. How quickly can we bring those lessons to the fore to practitioners, health practitioners who are supporting our veterans coast to coast? Folks, I am always shocked that I'm giving a brief when I'm supposed to be retired. But I tell you what, I would much rather be doing this than dog walking. That's what happens when you retire. Everybody knows you have time on your hands, and they ask you to take care of their puppies while they go off and do other important things. But the reality is I care so much about the well-being of our veterans. That's one of the reasons that I asked to be the Deputy Minister of Veterans Affairs. Nous avons eu un changement de culture avec
we had a change of culture in Veterans Affairs Canada
sur le soin, la compassion et le respect,
when we focused on care, compassion, and respect for all of our veterans and their families.
But the reality is that we need the expert advice of extraordinary centers of excellence like this one on chronic pain. And I am inspired by what I have heard today to see that you've advanced research and helped drive the development in the field of veteran chronic pain, how you have partnered with veterans across the board to research innovation, pain management therapies moving forward. The reality is that you are working and supporting families, because it's families, again, who are contributing so much to assisting the transition of our veterans and the well-being of our veterans. Again, we could have only served with the care and the love and the support of our families. And so I appreciate that you're focusing on supporting families with the research. And this important focus on education, because it's only with the education that will allow our veterans and their families to take ownership of how they can manage their individual circumstances going into the future. Encore, le focus de formation et d'éducation,
the focus on training and education is essential for the welfare of our veterans in the long term.
I also appreciate the fact that you're focusing on unique solutions. Again, every one of us made a decision, made a choice to join the armed forces, where a value of the armed forces was service before self. Encore, the valeur de service.
The value is service before self. A professional force, a dedicated force. That is the key value.
And we know that our forces, members of the forces, are the force of last resort for the country. That they serve so that others may live, as the search and rescue community say, as the special forces say, we will find a way. And we know that in every unit, in all of the services, we know that folks are so professional that they want to train with their comrades, with their battle buddies, shipmates, wingmates, that they want to deploy. And they want to deploy. And I still remember handing out coins to folks in Afghanistan who are on their 4th, 5th, 6th, 7th mission in an operation. And when you ask them the question, why are you here? They would always say, sir, because I want to be here. And then I would ask, did you tell your family that? And they said, heck no, we'd be in too much trouble if we said that. But the reality is that they put their own pain aside, like just elite athletes, that they would put their service ahead of everything else and make a choice to go out the door so that others may live, so that others would be secure. Encore, une force bien dédiée et professionnelle.
Our forces are dedicated and professional to the service of our country, but again, to service with colleagues, with friends in difficult situations.
With that, it is so important that we find solutions that fit each individual veteran, that we educate them, we give them the tools We give them the knowledge. We give them the experience so that they can take ownership of their unique circumstance. Every one of us saw unique service. Every one of us needs unique solutions going forward. I also appreciate that the Center of Excellence have focused on a veteran-centric approach. This is so important. Working directly with veterans informs your research agenda and helps determine priorities for potential research. And appreciate what the Advisory Council for Veterans has been able to do to improving knowledge of military life among the civilian healthcare providers across the country. And that's what's so key. We cannot hold this information. We need to share this information across the country. C'est vraiment essentiel qu'on partage
really essential that we share this knowledge, that we share this experience as soon as we gather it, and with all participants across our country as soon as possible.
And indeed, leveraging all the veteran peer coaches and improving veteran well-being across the board. And I know that everyone here fully understands the impact of chronic pain. We have learned that veterans' experience in chronic pain is twice as much as the general Canadian population. And it kind of captures just how unique a population that we have. And we understand the impact on mental health, as Dr. Buckley mentioned earlier today. Mais c'est vraiment essentiel à partager cet
It's really essential to share that information with all health professionals across the country.
I would also want to say that the partnership with those in the Canadian Armed Forces, the Surgeon General, and those who are serving in the medical branch is so important. So we start the solutions as early as possible. On a un défi, c'est surtout avec les
we have a challenge, especially with the young soldiers.
À cause d'eux, ils sont très capables.
They feel that
ils sont vraiment invincibles.
They are invincible.
That young folks in the Canadian Armed Forces feel as if they're invincible. And therefore, they can keep on going, notwithstanding the pain. And how many of us have been in on a parachute jump, and there's folks just taking Motrin before a jump because they want to be there, they want to jump with their battle buddies. We need to ensure that we are treating folks early on and giving them the knowledge early on, and similarly supporting those family members because we know it's the family members who are going to drag in their service members in order to get medical attention sooner than later. So I just want to say how much I appreciate what the Center of Excellence has done. I think there's a cane that's going to pull me off because I know I only have a moment to go, but I am thrilled seeing the progress you have made. C'est seulement un an, mais vraiment sur cet anniversaire, le progrès, c'est incroyable. Je veux dire seulement, allez-y. Away you go, as the 5e Brigade says, allez-y, allons-y vraiment. Let's get going. Continue to focus on those unique solutions for veterans. Ensure that we partner and share this information, and let's move out. Aussitôt que possible, en besoin cet renseignement.
As soon
Merci
as possible.
À vous. Thanks very much, and I'll turn it back to the chair.
Thank you, Walter, for those inspiring words. As we close today's forum, I would like to thank the Minister of Veteran Affairs Canada, the Honourable Lawrence Macaulay, and the former Deputy Minister of Veteran Affairs Canada, Walter Natinchuk, for speaking today. I also want to thank the other speakers, Dr. Ramesh Zacharias, Dr. Jason Bussa, and Dr. Norm Buckley, for their contributions to the Centre and their commitment to working with the veterans to find solutions to the challenge of chronic pain among Canadian veterans. De plus, merci à tous ceux qui ont participé.
In addition, thank you to all of you who attended the first annual Open Forum. For the most up-to-date information about the Centre of Excellence, please head to our website, veteranschronicpain.ca, and sign up for our mailing list.
For those of you interested in receiving updates from the Centre of Excellence, please see our website, veteranschronicpain.ca, to sign up for our mailing list. Thank you all for your attendance, and have a wonderful rest of your day. Merci à tous, et bon après-midi.